finally, a source of raw, real, and honest information on healthcare issues that matter most. Welcome to BS Free MD. From the latest medical information to how to stay sane as a doctor or a patient, no subject is taboo, and no BS is allowed. Now, let's welcome your hosts, Doctors May and Tim Hindmarsh.
All right, this week we are going to talk about all the many cancer awarenesses. There literally is the only month that does not have a cancer awareness, a kind of cancer associated with it is August. August is cancer-free month. Every other month has some sort of cancer associated with it as far as awareness, which makes me want to start an awareness campaign for awareness. It really is amazing.
August is maybe cancer-free.
It may be cancer-free, but September, October, November kind of hit the really big cancers that tend to kill people. It's the beginning of the NFL season. Breast cancer awareness kind of blew all this stuff up, so now it's Crucial Catch, and they have these shirts with like a million different colored sort of ribbons on them for every single kind of cancer you can get, which I guess makes sense. I suppose. So colon cancer is probably the brown stripe, I would assume.
Oh, stop. Before you digress, it's story time. Brought to you by locumstory.com. And today, you know it, I'm reading One Job, Two Job. One job, two jobs. Red blob, no job. Elective doc, emergency doc. Some in overstock, some in out of stock. This doc is too abused. This doc is underused. This doc can't get sick. Say, let's try a brand new trick. For all the docs about to cry, here's an idea you can try. Look into a locum tenens assignment. A really great option, you might find it. Don't forget, locums pays much better, and you can find assignments in any type of weather. With all this new info trapped up in your thinker, go to financialresidency.com/locumstory and use your mouse to tinker. It's here you'll find the unbiased answers you are after, so you can decide if locum tenens is your next chapter.
Hello, and I'm super excited to let everybody know that something Tim and I are actually part of, and we want you to join us. It's the Marriage and Money MD Conference. This is taking place on November 15th through the 17th, and it's a free live event. Why don't you grow your marriage and your wealth? Every marriage has struggles, life is messy, and relationships are no exception. Our 18 speakers have lived through these struggles just like you, and they're here to offer their expertise to help you get the resources, tools, and encouragement you need to strengthen your marriage and your personal finances so you have a happy life and thriving marriage you deserve. At this free conference, you'll learn all these great things. You can find the link in the show notes today. It's going to be a face group event, so sign up online at marriageandmoneymd.heysummit.com that I've linked. If you decide that you want to upgrade to an all-access, a VIP pass for $99, you'll also get exclusive Q&A with our superstar speakers at the end of each night's conference. You'll also get lifetime access to the summit recordings by MP3 and enjoy over 8 hours of additional recorded interviews from the speakers. Of course, you'll also get a cool online mini course, the Financial Flight Plan, and just having fun with the bonus interviews with us. So check it out, Marriage and Money MD Conference, November 15th through the 17th. Remember, it's a free live event. I'll link in the show notes, and check out our social media posts. Hope to see you there.
Good job, man. You did a great job.
I'm getting some practice.
Yeah, you cannot believe how I was free associating words that rhymed with all that Dr. Seuss stuff, but none of it would be socially acceptable.
On that note,
so good job, Locum Story. You guys are going to be busy because there's going to be lots of openings and lots of doctors.
Yeah, I've been surfing their page, and they have some really great information on locums and backstory and all the different locums companies. And actually, it's an amazing website for any kind of questions with regards to locums. So check it out.
And for our non-physician listeners, locums are part-time jobs where you can travel around.
I call it the substitute doctor, like substitute teacher. You just go where you're needed, where you want to go, and say no if you don't want to go.
And you can do it all over the world.
Yeah.
I found 3 in New Zealand.
The
You can go to New
You're
Zealand
the fill-in. Oh, yeah, that's a popular place.
for a few months.
Yes. So we're doing all things cancer screening and awareness. We're talking and focusing on cancer screening today for you. We're not in primary care anymore, so this was kind of fun reviewing this and getting mostly up to date and making sure we have our facts correct, because we're not doing cancer screenings per se anymore.
That's cancer screening and not cancer screaming.
That was random. Well, I got to, me, I like fun facts. And before we get off into the weeds of the data on what cancer screening people need and when they need it, let's talk about this year in general. I mean, people really haven't been focusing on cancer screening because all things COVID kind of just tumultuated the whole world. And I was reading.
That's right. So there's no more cancer because of COVID.
Yeah.
There's no
there
more.
you go.
Any other disease doesn't matter. Only COVID matters.
Well, bing, wrong. I saw some information, and it was published in some of the British news, but I'm sure it's the same all around the world, where cancer screening in 2020 went way down. I think 2019 would have as well, because people, not 2019, what am I saying? 2020 data, and probably 2021 is what I mean, is because people are just afraid to, A, get out of the house and go anywhere. But then B, everything has been closed down. All elective procedures been way scaled back. So, I mean, I know that even actually true services are getting cut back for people that actually need chemo, etc. So cancer screenings have gone way down in the last 2 years for sure. But
well, not just screenings, treatments.
no, that's what I just said. Did you just not hear me? I just said,
right,
treatments. I mean, it's horrible. Treatments are being cut back. So obviously screenings, just like people I don't even want to go anywhere near a doctor. That's the last thing on my mind. I want to survive the pandemic. So people have put all these healthcare things on the back burner.
And elective cardiac procedures, which is a massive deal.
Right. So in 2020, what was the leading cause of death in the U.S.?
Heart disease.
Correct. Heart disease was still the leading cause of death, and the second leading cause of death was second leading cause. Does that even make sense? The second cause.
Second leading cause of death?
Yeah.
Was fungating ass cancer.
You're so funny. Yes.
Non-fungating ass cancer?
It's all cancers. And third cause of death in the U.S. was COVID. So heart disease was 690,000. Cancer was 598,000. COVID, 345,000. And this is for 2020.
Right.
Obviously, 2021.
So COVID was really like the sixth leading cause of death because of all those guys that died.
This is from
car wrecks and
CDC.gov and Morbidity Mortality Weekly Review, if we believe anything that comes from there anymore. But I thought that was just interesting because people are thinking COVID is all-consuming, and, cancer is still the second leading cause of death. So just a little from the latest stats that they conglomerated, which is 2018 true data, the latest for that year incidents and stats on United States cancer cases. There was 1.7 million new cases of cancer reported, and just about 600,000 people died of cancer. And then to make it simpler, for every 100,000 people, 436 new cancer cases were reported, and 149 people died of cancer.
Wow, that really brings a perspective into gear, especially when you look at comparing it to these COVID numbers, and especially the COVID child numbers that are super mega small when you're looking at numbers per 100,000, because the kind of average-ish United States level, Western Europe level of COVID was 12 to 15 per 100,000.
Yeah.
And those are cases. Those were those cases or fatalities? I can't remember. I don't want to misquote.
Wait, what was it? Sorry, say that
12
again.
to 15. Those must have been fatalities.
I think that's fatalities. Yeah.
12. But when you look at that and you go, that's almost 4 orders of magnitude worse for being diagnosed. So your chances of being diagnosed with cancer, just as a general stat, is 4 times. So almost half an order of magnitude worse than being mortared by COVID. Now, of course, there's a tremendous number of confounders in there, because cancer, just like COVID, is there's age criteria, there's risk criteria, there's all those things.
Right.
But that's the nature of any disease.
And then
right?
there's, we won't get into all the numbers on this, but then there's the, cancer numbers, the new diagnoses. Some are on the rise more than others, and then not everybody's dying from them. So, the diagnoses might be going up, but the treatments are staying stable or improving. But the other thing is that messes up the data is that there's more old people and there's more people in general in the world. So there's obviously more diagnoses of cancer when you have people living longer.
Right.
too.
We're going to talk about that and why I think that in a lot of respects, there's like the whole concept of preventative medicine is kind of stupid, is extremely expensive with very little fruit. But there are screening procedures that we'll talk about that are really, really helpful. Actually, I got the math wrong. I was thinking about that. If it's 12 to 400 and some, it is actually 4 orders of magnitude. It's 40 times. You're 40 times more likely to be diagnosed with cancer than you were to die of COVID.
Mm-hmm.
40 times.
So don't forget. Yeah, I mean, but it's all perspective, right?
Right, and it is all perspective. And
So-
again, not all COVIDs are created equal. You get COVID at 97. No, but you get COVID at 97 years
true.
old with a gazillion medical problems, and you get cancer at like 95.
Right.
Well, I mean, my family, that's probably what killed my mother at 92 years old. I mean, again, not a definitive diagnosis, but I mean, it was pretty clear. Okay, well, so you got cancer at 92. That's not that bad, right? You get breast cancer at 35. That's a major deal.
Exactly. So so if you look at the CDC website as far as all the stats, I mean, you can play around in there. It's pretty cool because you can change everything as far as populations, male, female, age groups, races, ethnicities, parts of the country where things are seem to be higher rates than others.
So, like West Virginia, everyone dies of lung cancer
Yeah,
because
like-
they're all coal miners that
I know it's
smoke.
bizarre. Like if you click on just basically all types of cancer for all ages, all races, all ethnicities, male and female per 100,000, just like the blanket thing, it's like huge in the Midwest and clumps in the South and in the Northeast. I'm like, well, that's really interesting. And then there's no data for. I think this is Nevada. Don't ask me why.
That's interesting though, because you really need to have like age demographics as well.
No,
right?
I know. But that was just like the blanket picture. I'm like, interesting. So, the other thing I wanted to toss out there, because people, and we're going to get to this, probably don't know the difference between what the most common cancers that are diagnosed versus the top 10 cancers that cause death. So, most common new cancer diagnoses. You know that? You should know that.
Well, skin cancer.
Top 10, I'm reading the top 10 cancers by rates of new cancer cases. Number 1 is female breast cancer.
There's more women diagnosed with breast cancer than people diagnosed with skin cancer.
Significantly. Look at that graph. It's 126.8 per 100,000. Now, that's true cancer. That's not false positives. The next one is prostate cancer, 107 per 100,000 people. Third is lung cancer. And this is across both sides. Number 4 is colon and rectum. 5th is uterine.
Damn near killed him.
And then, believe it or not, 6th is melanoma of the skin. And then it goes.
So hang on. Is this new I want to make sure I get this right. This is new diagnoses, not deaths?
Yes. Top 10 cancers by rates of new cancer cases. This is not deaths. This is new cancer cases. Because what we know is causes of death, right? That's what we go by. But these are new diagnoses.
So
the number one cancer being diagnosed is female breast cancer.
And that's per 100,000 of total population or 100,000 of women?
Total population, male and female, all races, all ethnicities. Based off 2018 data, that's the latest that they have all the data stats compiled for.
No,
always
that's really mind blowing because that's what are women? 50.5% of your population worldwide or whatever it is, just a little bit more than men.
Right.
So it's only half your population.
Yep. So
now men do get breast cancer. It's exceptionally rare, and you don't want to get it.
No, but that was female breast cancer. That's not men and women. That's not male and female breast cancer. But that's female breast cancer.
And they did not separate that. They said that's 126 per 100,000 of total population.
Correct. And second is prostate. Then third is lung. Colon cancer is fourth. Uterine cancer is fifth. And melanomas of the skin is sixth.
Well, melanoma is actually quite rare. So even if it's sixth, it's still...
Does it matter? Well, here we go.
And the same with uterine cancer. Uterine cancer is often not a big deal. And it's really quite rare. And it's not off. It's usually fairly easy to detect and fairly easy to treat.
And then seventh, I'll read the next one. 7th, 8th, 9th, and 10 is bladder, non-Hodgkin lymphoma, kidney and renal and pelvis, and then leukemias. So, let's talk about the top 10 cancers by rates of cancer death. What actually kills people? All ethnicities, all races, male and female. Per 100,000. Number one.
Lung cancer.
Correct. 34.8 per 100,000. So even though, that's third most common by new diagnosis, it's the number one killer. Number two is breast cancer, female breast cancer.
So that's really interesting. Let me just pause here. Because lung cancer is almost 100% associated with smoking. There are people that get lung cancer, primary lung cancer, that don't smoke, but it is exceedingly rare. So essentially, your number one cancer that kills you is a behavioral disease.
Yes, and it is like off the chart because it is 34.8 per 100,000, and the second cancer causing death drops to 19.8, basically 20. So quite significantly is female breast cancer. There's quite a drop. And then third cause of death is prostate cancer. Fourth is colon cancer. Fifth is pancreatic cancer.
Okay, so that's another thing that's really fascinating because prostate cancer often is like when it's really bad, it's really bad. Like if you're a 40-year-old guy that gets prostate cancer, it's more treatable now than it used to be, but that's a big deal.
Right, but I would say that, this data, this prostate cancer, is that it's a disease of older men usually that's the cause of death.
But
generally,
but the point is, if you're over 80, you're not going to get treatment for prostate cancer, right?
Correct.
Because but your cause of death is not going to be prostate cancer. Your cause of death is going to be a stroke or a heart attack.
True.
Statistically speaking.
Correct.
So the fact that it kills you means it's disproportionately killing younger men. It's killing men in their 50s and 60s is what that means.
I don't know exact data.
But
I don't know because you could
that's
say that men
a
in their 50s
logical
and 60s
extrapolation.
could be having cardiac events as well.
Now, is this the United States or the entire world?
United States. This is U.S.
So I'm really floored by that lung cancer statistic.
It's amazing.
Like it blows breast cancer away as far as fatalities.
Bill,
it's almost double?
It's 34.8 per 100,000. Breast cancer, say 20. So 35
it's
to 20.
Significant.
Yeah.
It's like a 40. What is that?
15 per 100,000 more.
Yeah. So what is that? Like a third more? 33% or 40%?
Get my calculator.
No, but that's a significant difference.
So, the interesting thing is, like we said, you've got uterine cancer and, melanoma and skin cancer, like in the top new diagnoses, but they're not killing people. So, really interesting stuff.
Well, the other thing that you can glean out of that's really interesting that dovetails perfect into what we're going to talk about next is colon cancer used to be like number 2 or number 3. And now it's like 5 or 6. And That's like the fact that people die more commonly. Two of the top 3 cancers that kill you are sex specific. Okay, so a man can technically die of breast cancer. A woman can't die of prostate cancer because she don't got no prostate other than Caitlyn Jenner. But that's a side
in the
right. No,
olden days.
Right in
that's all I'm
the
gonna say
when
of medicine.
when we believed that sex and genitals actually gender and genitals were the same. When we were the G&G crew, but that's a different story. We shall not digress. But they're sex specific. Like 2 of the 3 are sex specific, which is amazing. Colon cancer, kills men, women, whatever.
Correct.
Plus, our junkie diets and drinking too much and smoking too much and doing all the things that we like to do for fun, ramp up your risk of colon cancer like crazy. What that tells me is colon cancer screening is a mind blower that's saving tons and tons of people's lives.
Yeah, well, when we get to talking about lung cancer screening, I was blown away because actually November is also Lung Cancer Awareness Month. And here, I have it right here. Basically, they did a survey and they said that only, 36% of people know that lung cancer screening is even available. I mean...
Which is odd. And
then, of course, 29% of people know that lung cancer is the leading cancer killer of men and women. So, I mean, even more than that, people don't even know that there's lung cancer screening available. I mean, everybody knows about a colonoscopy.
Right, but lung cancer
get
screening...
Get your moles checked, get your boobs squished, get your testicles examined. But do people know that there's lung cancer screening?
Maybe this is the problem. The problem is lung cancer screening is a low-intensity CT scan. So all you have to do is lay on a table for like 15 minutes. It's really relaxing, unless you're wildly claustrophobic, which, but it's way better than an MRI. It's actually you can put headphones on. Maybe the fact that it's not unpleasant is why people don't do it, because it has to be unpleasant. This is, if you smoke and haven't quit for more than 15 years and have 20 or 30 pack years of smoking, it's really super easy to screen patients for this. They get a low intensity CT scan, and it's actually been shown to be really helpful at detecting lung cancers, which is a big deal, because if you get lung cancer super early and you can treat it surgically, you can cure it.
Right.
Okay. And so maybe we need to make the lung cancer screening test way more unpleasant than more people will do it. Like where you have to do like the colon prep, or you have to get your breasts like squished until like your nipples shoot off your body or whatever, because those screening tests seem to be quite popular.
I think we should trade. I think all women should try to experience what a man goes through for testicular cancer, and guys should get their chest nipples squeezed so you know what it's like.
Testicular screening is...
Because, they have all those bellies that guys wear to try to pretend like they're pregnant. So why not just share what it's like to, do the cervical pap screening and all that? Is that a bad idea?
And how do you propose physically that happens?
They can scrape some skin from your netherworld. I don't know. You're looking like you're grimacing with delight. Anyway.
I don't know.
We digress. We're getting a little goofy. But, so yeah, when... It's fascinating how people aren't aware of that. And so they're on a big push this month. The Lung Association is, and they have I'll link that page. It's really cool. And you can even do a little quiz on there that talks whether or not you are needing to be screened for lung cancer based on your history and risks, which we'll get into in a little bit.
If you are a middle-aged smoker, you need a screening test for lung cancer. And it's not a big deal. It might be a big deal that's the other thing. In the United States and I don't know what the coverages are in other parts of the world, but is it hard to get covered on insurance because it's not a cheap test, but it's not terribly expensive? I mean, it's got to be way cheaper than a colonoscopy.
Well,
it's a CT scan, for heaven's sakes.
Yeah, so if we're going by the U.S. Preventative Services Task Force, the USPSTF recommendations, which is pretty much what everybody looks to as the standard.
Let's time out there for 1 second. So what is the U.S. Preventative Services Task Force? The USPSTF.
Yes.
USPSTF. We're here to prevent disease today. Yeah. So it is a group of experts that are primary care experts. So family doctors, OBGYNs, pediatricians, et cetera, et cetera. And they are volunteers. They do not get paid to be on this committee. They all have to disclose any financial interest they have at all. And I actually looked up the list of doctors that are on the USPSTF. And like most of them, what they're discussing are, as far as financial disclosures, are not industry. Like it's not like I worked for Pfizer and I'm the chief vaccinologist for Pfizer and now I'm on the CDC committee, which actually happened.
Yeah.
So basically what they said is they're researchers and clinicians, and they get grants. So, Joe Blow got a grant to study aspirin prevention. So then they have to disclose that. If the grant's over $1,000, and they disclose all. I mean, there's all these, and so it's really, really buttoned up as far as financial bias. It is biased to primary care, and here is the critical piece to the puzzle with their recommendations. And this is really, really, really important. This is for people with no signs or symptoms of disease. Okay?
Yes, what we're talking about exactly. It's not when someone's had disease being followed by an oncologist or anything else.
But here's a critical piece. So a screening test by definition, and this is the thing, like their book is very small because there's very few things that are highly recommended by very, very good evidence that prevent much of anything. If it's a screening test, and a real screening test means you have absolutely no signs or symptoms, of that body part area. So, for instance, the U.S. Preventive Services Task Force got into all sorts of hot water because they recommended against routine prostate-specific antigen testing as a screening test. Okay? Now, what does that mean? What does that mean in clinical practice? That means if you have a 45-year-old or a 50-year-old guy that has 0 urinary tract symptoms, 0, and you just routinely do the PSA blood test on them.
The PSA is the prostate-specific antigen
The
test.
test itself is not good enough and sensitive enough, and the potential for harm is high enough in having a spuriously high prostate-specific antigen test where you would potentially get a biopsy or an ultrasound,
right.
which prostate ultrasound is not necessarily pleasant. For some guys, they might really like it. It is an ultrasound probe up your keister. The biopsy is horrific. It is ultrasound probe.
Used to be the standard of care is to do PSAs on patients.
Right. So the thing is this, though, okay? Who does that eliminate from screening? Well, it eliminates a lot of men. But if you come in and you say to your family doctor, you're getting an annual exam, and you say, well, I get up 3 times a night to pee. Boom, that's a symptom. So now you do a PSA. It's not a screening test.
Correct.
Now it's not a screening test. Now it's a diagnostic test.
It's part of it, exactly.
And people,
just like we don't do random throat swabs on people for strep when they're not having a sore throat or a fever, or we detect a whole bunch of positive streps.
And so it's because the threat for harm in screening tests is actually quite high.
Yeah, and we'll run into this when we talk about breast cancer screening with mammograms too.
Is literally breast cancer screening is a literal minefield.
Yes.
It's a minefield of little boobs all over, but it is a minefield.
Oh, gosh.
Some bigger than others.
Okay, so are we going to get into the USP?
But yeah, we will.
Recommendations.
But it's really. But I just want to stress that because if you go into because people hear this and they hear it in the popular media and they hear routine PSA is not required. Okay, and the evidence backs it up. I think that's reasonable. But what's routine? You go to your doctor and you have erectile dysfunction. That's a symptom,
right?
And so. And how many guys that are 60 don't have any urinary tract issues?
A better example would be doing, like I said, mammography on women because, we're talking about having no breast lumps, or even cervical cancer screening. That's changed again, now that we have the HPV testing. And so most people aren't complaining of cervical issues. So it's PAPs and that's screening.
But the absolute gold standard, I think the gold standard's changed now with colon cancer screening, but the absolute gold standard for a screening test was the Pap smear. And this is why. This is really important to understand, okay? You could do it on 100% of women, over 21, which is the recommendation now, okay? So you did it on 100% of women. It detected cancer like before symptoms, which if you have symptoms of cervical cancer, you're going to die. Mm-hmm. So it detected it when you couldn't possibly detect it yourself, and it detected it early enough that you could do an intervention that would change the course of the cancer. And probably most importantly, it's a minimally invasive test. In other words, you're not going to kill somebody with a Pap smear.
You're not having. I mean, it's
right. Where I guarantee you, someone's been killed from a.
It's an an office visit. It's not like you need a whole day off after the like a biopsy.
But somebody's been killed from a routine colonoscopy for sure.
Correct.
They've had a bowel perforation and died. Right. Like there's no question that that's happened with the gazillion colonoscopies we've done. So super low downside, super high upside.
Right.
And then we've done them for what, like 60 some years now. Or so, something like that. I mean, it's really an old test. And now we figured out, okay, well, who gets cervical cancer? Well, the more sexual partners you have, the higher risk you have of HPV. And so now that screening has gone way, 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 way down. Now you get it every 3 years, and some women get it every 5 years. And, the screening has been dialed in so perfectly because that was the gold standard test, and it continued to evolve. I mean, it really is a great piece of healthcare.
So we're going to go through them for people one at a time, so we can simplify it and they can follow along.
So
on what they need to get.
If you look
checked.
at cancer screenings,
I have it by age. You want to do it by age, or you want to do it by risk factors? I have screening for cancer types based on age. First off, the recommendation starting at 21 to 29 is cervical cancer screening. So in your 20s, they're recommending Pap test every 3 years.
Yeah, and then if you get into the high risk group, they do HPV and all that.
So then for cervical cancer screening, you're starting in your 20s. People ask me all the time, I have kids that come in that are 11 that have started their period. When do they need screening for cervical cancer? So it's based on sexual activity, sometimes hormone replacement, family history, high risk. But basically, you can actually even, some places say wait till age 25. USPTF says starting at 21. And for women 30 to 65 years old, you can screen every 3 years with a Pap smear alone. You don't have to go in every year, girls. Like, I know some people that like to go in every year and get this done. I don't know why, but it's every 3 years if they're normal. If they're abnormal, that changes. Now, it's not a screening of a healthy person. So every 3 years, or you can do every 5 years if you're doing high-risk HPV testing alone. So your doctor does an HPV screening test in that Pap, or you can do every 5 years with HR-HPV testing in combination with the Pap smear. So that's a grade A recommendation. You want to explain?
It's one of the only grade A recommendations.
It basically means there's high certainty that the net benefit is substantial, and they have grade A through D. So grade A means like it's very obvious that that's substantial, and then you do that up until age 65. After age 65, we're not doing Pap smears anymore.
No.
And I have people that ask. Women would come in, do I need a Pap? No.
The grade A is USPSTF recommends this service. There is high certainty that the net benefit is substantial. So based on
I think I just said that.
Review, yeah. B is
And
they recommend the service. There's high certainty that the net benefit is moderate, or there is moderate certainty that the net benefit is moderate to substantial. C is basically neutral, and they said selectively offering the service to individuals, based on risk. D is that the harm outweighs the benefit.
there you go. And so we have some of those C and D recommendations that we'll throw at you later. But so absolutely A. And they revised that recommendation just recently because it used to be, we didn't used to have that HPV test that you could use. It was just cervical cytology only, just the scraping of the cells off of there. So they keep revamping things. I mean, you couldn't go every 5 years before. Now you can. What a cool thing. Who wants to go every year for a PAP? Now you can wait every 5 years if you're always negative and your high-risk HPV test is negative. So moving along, okay, that's the cervical cancer screening. Moving on into your 30 to 39-year-old age group, basically still nothing. And people are thinking, I'm sure they're thinking this already, what about skin cancer screening? And routine screening of the whole body is not recommended for adults. I know that when we went to school, they used to teach us that every year with the physical exam, you're supposed to do like a whole body skin screening on everybody. Not helpful unless people are pointing out things or there's a family history of skin
I
cancers.
actually recommend that you do an entire full body screening of me.
Yes.
Way more
I'll
than
check your toenails. And
way more often than you are.
And since we're on that path, I'll let everybody know that I did that. Tim had this thing on his toe that looked like a melanoma, and it was bugging me because it'd been there for a year. And I'm like, that toenail's loose. We got to take that off because it might need a biopsy. And I ripped his toenail off. And it was blood, dried blood.
Yeah.
But it was, hey, a diagnostic
That's what
test.
happens when you go to medical school.
When you're married
you go to
to
medical
doctors.
school in Cambodia.
Stop it. Anyway, we fixed that ugly toenail. So recommended screening for skin cancer by annual exam. No, the USPTF does not recommend it. So, okay, that's covering cervical and skin cancer. And now we're up to age 40. Oh, it all goes downhill at age 40 and wait till 50. It gets even better. So now we're talking about breast cancer. It's the next in line for screening. And it's going to vary, but the USPTF says that from age 40 to 49, they recommend you ask your medical provider about your risk for breast cancer. So it's not a standard thing in the 40s for women to be screened. Depends on a lot of factors, and the biggest one is going to be family history.
Yeah, family history is massive in this. And it's interesting because I saw a stat, this was a few years ago, I think it still holds true, that if you routinely start breast cancer screening at 40, and do it like annually at 40, I think it was annually, then you increase the risk of having a procedure done by 10-fold. In other words, like a biopsy, a giant needle stuck in your breast, by 10-fold.
Yeah, that's a little
for
high.
every cancer you're going to find. Every extra cancer. So there's a lot of devil in the details there.
I was looking at that because I knew you'd bring that up. And they have compiled all this data on breast, how many breast cancer deaths were avoided by doing early screening and how much harm from mammography even yearly to every other year in the age groups. It's not tenfold, but definitely, let's see. This is from, I think, compiled from 2016. This was published that I found from the web, and I have to double check and see. I think they compiled all the data, but by 2016, they were finding that false positive mammograms in the 40 to 49-year-old group were just around 1,000 per 10,000 women screened. Okay, 1,000 women
10%?
Out of 10,000, compared to the 50 to 59-year-old, like 932. Believe it or not. Harms of one-time mammography screening per 10,000 women screened, Breast Cancer Surveillance Consortium data. That's what this is. So it is higher. false positives. But what happens then is how many get a breast biopsy. So in the 40 to 49-year-old, 164 getting breast biopsies, and then 10 of those women would get a false false negative mammogram. The ages 50 to 59, like I said, it was pretty close, 932 false positive mammograms, and then there was about the same number of breast biopsies, 160 women compared to 164. And that number actually starts to go up even in the breast biopsies in older age groups. So it's not that 10 times as much, but it's still pretty significant.
Right, but and the thing is though, like, because remember we interviewed a physician in her mid-40s who had breast cancer, and so the critical piece to this puzzle is risk factors. If you have especially family history, then yes, you're going to get screened at 40. You might get screened at 35 if you find a lump. If your husband finds a lump, if the cable guy finds a lump, then you're gonna want to, then it's a completely different level of intervention. If you have breast discharge, bloody discharge, et cetera,
Right.
et cetera, et cetera.
So then, that begs the question, well, how many lives are you saving by doing that earlier screening, right? Are you saving enough lives to make it warranted despite finding a bunch of false positive ones? And they found that the breast cancer deaths avoided per 10,000 women by doing the screenings at age 40 to 49, or 3 per 10,000 compared to 8 per 10,000 in the 50 to 59-year-old age group.
Right, and part of this is the limits of mammography.
Yeah.
I mean, and that's what drives me super crazy about a lot of these awareness campaigns. It's just like, it's like the insanity that's going on with the vaccine now. It's like if you get your mammogram, then you're safe. Well, no, you're not, because mammograms aren't that good. That's the problem. I mean, we may end up with breast MRI is way better, but breast MRI is a nightmare because you're stuck in an MRI machine for like an hour or whatever it is. So, and it's super expensive.
Yeah. So the recommendations now by the USPSTF, grade B recommendation, is that you do biannual, which is
every other
year screening mammography for women ages 50 to 74 years of age.
After 74, the only squeezing you get
well, you're just doing your own
the new
breast
guy
exams.
the new guy that moved into the assisted living facility.
Yeah, there's insufficient evidence to balance the benefits versus the harms after 75, obviously. Now, if you have, and then we're not going to get into this, but if there is a family history for breast cancer, and you're doing all the hormonal screening with the BRCA gene, etc., then that does change. So
no, once you get into really bad family history and the BRCA gene and all, that's a completely different line.
I want people to remember that we're talking about negative history. Then
you get into preventative use of prophylactic tamoxifen.
Yes.
I mean, there's a whole bunch of stuff that comes out of that. We're not going to get into
really good data for using that preventatively. But we're just talking about no risk, no history. There you go. So now we're on to the glorious 50s when it all starts to happen, all the screenings, right? So now we're still doing our cervical screening, our mammograms, our own skin exams, and what comes next, everybody knows, the lovely colonoscopy. So, what ways are there to do a colonoscopy screening, Tim? Colonoscopy screening, oh my gosh.
Only one way. It's called a colonoscopy.
What ways are there? Yeah. So let's talk about the different kinds of colon cancer screening.
So there's occult blood screening, where you look for microscopic blood in the stool. There is genetic testing, like the FIT test, and then there's colonoscopy.
Well, the FIT test is the fecal immune test.
Immune test.
It's not genetic testing. I had to look that up too, because I'm like, FIT test. What the heck's that? Basically, it is just more specific than the occult blood, so it's not sensitive to anti-inflammatories like NSAIDs. You don't have to stop taking those. It also doesn't get skewed by eating, red meats and certain dyes and things. So it makes it easier for people to
it's
do.
a more specific.
Yeah, and it's pretty much
right.
essentially like doing the fecal occult blood, the home kit testing. So there's a lot of different commercial ones that people can buy. They're really pretty, like 95 to 98% accurate, shipped to your own home. You get your little box, your kit in the mail, and you mail it back. Those are usually fit tests.
You ship shit. She ships
Yes.
shit by the seashore.
Gone are the days of the doctor doing your nice little rectal exam and stool sample fecal occult blood
That's
test,
right.
because it's only one
That's right.
sample.
It's
and
like
you
all
need
my right. Like
3.
all my buddies when we were in our 30s, it's like, yeah, when I turn 40, you're gonna have to stick your finger up my ass. And I said, no evidence that helps. Now, if you want me
Well,
to,
it helps, but you have to do it 3 times
that's
on 3 different days.
no. But even like digital rectal exam for prostate, completely
correct.
worthless.
Sorry, correct.
The finger wave.
I thought you meant
The finger wave. The finger
the
wave.
fobbed,
You need that's a 2-drink minimum.
the
for me.
fobbed test. So that's why they send you home with those. Now, those you have to do annually. That means every year. So if you're going to do those, they should be done yearly. Otherwise, you get to do what most of us do, which is a colonoscopy. So for screening, colonoscopy with no family history, negative issues, it's still recommended every 10 years. Now,
Yeah,
I know a lot of people.
they're starting at 45 now.
Now,
instead of-
I know a lot of people go earlier based on family history, and a lot of people go more often, every 5 years, depending on if they find a polyp or family history.
So general rule is 50, and if it's negative, it's every 10 years till
yes,
like
every
70.
10 years.
And then if they find polyps, then the whole paradigm shifts.
Correct.
And if you have a family history of colon cancer, you go 10
10
years
years.
before the youngest member of your family. So if your mother had colon cancer at 40, you're getting a colonoscopy at 30, and that's colonoscopy. Like, you're not doing fit testing or any of that other stuff at that point. You're going straight to it. This test has undoubtedly extended my life. I don't think there's even a question of that. Family history of colon cancer. I had polyps. I didn't have polyps at 43. I had them by my early, by like 49. And then the good news is, when they find precancerous polyps, they're taking them out so they can't become cancer. So a colonoscopy not only screens you for the disease, it helps prevent progression of precancerous lesions to cancer.
Right.
And
So
I've had a lot of
that's grade A
colonoscopies.
evidence, and that's 50 to 75 years, not 70. 50 to 75 years of age, colonoscopy screening. After that's from 76 on to 85, they say that it's selective screening, just depends on the age group, depends
Right, so
what's
you have a
going on. But that's
super-
grade C evidence.
Right.
So my dad, that's it now, almost 86 years old. I don't know why his doctor's doing a fit test on him. I guess it's just for his fun, but it's stupid.
But the thing is with that, like, you have a super fit 76-year-old that might make it to 96 that has reasonable risk, had polyps before.
Correct.
Be a no-brainer to screen that
Yeah.
person.
I mean, everybody's got specific health
That's why
history.
discussing these details, especially with breast and colon cancer, where there's and then we'll get into prostate, is super important, because all of this stuff is really individual, and it's part of my awareness campaigns, where they advertise all this stuff. I guess it's helpful to a certain degree to have the popular media doing it, but it really should just be, see your doctor. Well, I don't have one.
Right.
Yeah, okay, that's a problem. That's a different problem.
You don't. Okay, on to the next one, which is lung cancer. Starting at age 55 through 80, annual imaging screening for current or former smokers. And the actual information is current heavy smokers or those who have quit within the past 15 years are eligible. This is covered by insurance. Heavy smoking is defined as 2 packs of cigarettes a day for 15 years or 1 pack of cigarettes a day for 30 years. So they calculate as pack years. You do the math.
But it's
Or half a pack of cigarettes a day for 60 years. So you have to equal 30 pack years to be considered a heavy smoker.
Really? Okay, but the U.S. PSTF says 50 to 80 who have a 20-pack year smoking history and currently smoke or have quit within the past 15 years.
Is that
That's brand new.
oh, I stand corrected.
So they lessened it.
Yes,
they lessened it to 20-pack years. So if you started, so for instance,
yes,
if
they
you,
actually changed that as of 2021.
March of 2021.
Yes, my bad. We'll read that again because I read off the chart I had was the old data.
I'll try to make it simple. If you are a smoker who has smoked for a pack a day for 20 years and you're 50, there's good evidence to get a screening test, which is a low-intensity CT scan of your lungs to look for early lung cancer lesions. That can be a total game changer because, again, right cancer at the right time with regards to lung cancer. If you have the right kind of lung cancer and it's found early, it's curable. Okay,
Yeah.
Colon cancer found early is curable,
and that's 50 to 80. They extended
Right.
it another 5 years. So
which tells
what
you
I said
right,
was
like
incorrect.
80.
Yeah, and this is grade B evidence. Correct. 50 to 80 years who've had a 20-pack year history of smoking. Now, the other thing is, remember, if you quit within the past 15 years, it doesn't say how many pack years.
But if you've quit for over 15 years, you don't need the screening.
Correct.
Because then the radiation from the CT scan is probably worse for you than the...
Yes, and this is still low-dose CT scan that they're using. So please, we'll share this information with you. Let's throw in the prostate screening. Well, I think we kind of covered that, but the recommendations for prostate screening now is silence.
Yeah, it's all over the frickin' map. Because the screening test sucks.
Yeah. It basically says, ask your doctor about your risk and the benefits and harms of screening for prostate from ages 55 to 69. That's the last I had on there.
Yeah.
Fact.
There's no real routine.
It's not fun.
Yeah, because
And
there's no real routine screening test. That's the problem. So if you're getting up a bunch of times in the middle of the night to pee or whatever, then get a PSA and they can fractionate it and do all the stuff with it and try to diagnose your prostate cancer. But the screening stinks for it.
Get this. I was blown away. I did not know this when I was reading about prostate cancer screening. But did you know that the rate of prostate cancer for black men compared to white men is like off the charts? It's like way higher.
Way higher which way?
Black males have a way higher incidence of prostate cancer.
Yeah, but lots of stuff is like that.
And the reason being is not anything related genetically. It is more related to socioeconomic disparities. But they're 2.5 times more likely to die of the disease as well. Not just the incidence, but they're 2.5 times more likely to die of prostate cancer.
Yeah, but dying is different because if you don't have access to health care, et cetera.
Sorry, I said it incorrectly. That they don't have an increased risk of dying from it. They just actually do better for some reason that they find once they're diagnosed to get treated.
Did you find the other prostate cancer tidbit that if you have increased numbers of ejaculations, you have less risk of prostate cancer?
I think that's
It's not.
It's not an urban myth?
No.
Really? No, I did not find that.
So it gives.
You probably went looking. I didn't.
It gives the term "you're killing me, Smalls" a completely different meaning. It's true. I know. I don't know how much of a difference it makes. Not saying I wouldn't want to find out, but I'm just telling you.
Well, I'm distracted now, but what I wanted to finish saying was they basically adjusted for various variables and across all these different data sets and studies that they've done that apparently, that black men die more from other causes too, like heart disease compared to white men. And they think, a lot of it has to do with access to health care, socioeconomic inequities, etc. But it's fascinating how that, because they have a lower prostate cancer mortality rate than white men, stage for stage basis, and that they're more easily cured with radiation therapy, but yet they are diagnosed way higher, and they think it's just lack of that.
It-
I
it-
found that
it-
interesting.
It does remind me, though, my prostate, because now I'm completely on a bunny trail. But it reminds me of that joke where the guy goes in, he had a bunch of tests done, he had all these symptoms, he has a bunch of tests done, he goes in to see his doctor, and he goes, I really need to talk to your wife first about your diagnosis. And so he's sitting out in the waiting room, and the doctor says, I've got really good news for you. Your husband has this really terrible disease, but it's exceptionally treatable. Okay, it's 100% fatal in 6 months untreated, but if it's treated, he'll have a normal lifespan. And the treatment is you need to have sex with him twice a day. The wife hears that, and she nods, and she walks out, and her husband's sitting in the waiting room, and he's like, "What did the doctor say? What did the doctor say?" He said, "You're gonna die."
Yep, you are.
You're gonna die.
You're gonna die. So yeah, this month, lots of awarenesses. Like we said, it is the Lung Cancer Awareness Month, Gastric Cancer Awareness Month, Pancreatic Cancer Awareness Month, and Carcinoid Cancer Awareness Month, which is dear to my heart, as my mom was diagnosed with carcinoid and passed from that. So everybody get your screening done. We will link all of the information where you can get to the U.S. Preventative Services Task Force.org, as well as some other websites that have information, one of them being CDC, etc.
And, just a shout out, it really does matter talking to an expert about this, so talk to your doctor about this kind of stuff. The other thing that's really important is even smallish symptoms, once you get past, 50, 55, 60, can be a major deal, so don't ignore that stuff.
Perfect. Thanks again to our sponsor, Locum Story. We will link them in the show notes. You can check it out if you or someone you know is interested in doing locums as a substitute doctor. We hope to have some other interesting stories and tales, personal stories of some survivors of cancer this month, and we are really excited about those interviews. If you like us, share our page, share our podcast with a friend.
Okay, well, that's it for this week. We'll see you next week, and we have some really cool stuff coming that we can't wait to share with you.
Hello, and I'm super excited to let everybody know that something Tim and I are actually part of, and we want you to join us. It's the Marriage and Money MD Conference. This is taking place on November 15th through the 17th, and it's a free live event. Why don't you grow your marriage and your wealth? Every marriage has struggles, life is messy, and relationships are no exception. Our 18 speakers have lived through these struggles just like you, and they're here to offer their expertise to help you get the resources, tools, and encouragement you need to strengthen your marriage and your personal finances so you have a happy life and thriving marriage you deserve. At this free conference, you'll learn all these great things. You can find the link in the show notes today. It's going to be a face group event, so sign up online at marriageandmoneymd.heysummit.com that I've linked. If you decide that you want to upgrade to an all-access, a VIP pass for $99, you'll also get exclusive Q&A with our superstar speakers at the end of each night's conference. You'll also get lifetime access to the summit recordings by MP3 and enjoy over 8 hours of additional recorded interviews from the speakers. Of course, you'll also get a cool online mini course, the Financial Flight Plan, and just having fun with the bonus interviews with us. So check it out, Marriage and Money MD Conference, November 15th through the 17th. Remember, it's a free live event. I'll link in the show notes, and check out our social media posts. Hope to see you there.
It's no secret that medicine is a bit uptight. That's why Tim and I created BS Free MD, to mix things up a little and have fun in the process. Besides, we are having these exact same discussions all the time, so we thought we might as well invite everyone to the party. If you really like us, you can get plenty more and maybe see one of Tim's cool tattoos on our Instagram or Facebook pages at BS Free MD. See you next time.
try to keep BS Free MD as raw and real as possible, we can't be held responsible for any medical decisions or discussions had as a result of what you've heard on the show. We know, bummer. But the truth is, we really do care about your questions. So feel free to reach out to us by email at doc@bsfreemd.com.
Thanks for listening.
I don't care even if you don't like us, share it. Just share it. Don't be a dick.
Just share.
You get fungating ass cancer if you don't share it. I think that's what happens. It's true. It's a major risk factor, even for non-fungating ass cancer.
I think that's a blooper.
Whatever.